So got most people in here. So why don't we go ahead and get started? Good morning or good afternoon, depending on where you are. I'm Stephanie Trudeau. I'm past chair of the Families and Health SIG, and I'm stepping in for Dr. Ruth Netting today. Just want to thank you all for joining us. We're super excited to have Dr. Jessica Goodman presenting today. Today's webinar topic is equipping healthcare providers to work systemically with patients and families during telehealth visits. Before I turn it over to Dr. Goodman, I want to give a little formal introduction about her. She is also part of our SIG leadership team. She completed her PhD in medical family therapy at ECU. She's currently a postdoc fellow within the Department of Psychiatry and Internal Medicine at the University of Rochester School of Medicine and Dentistry. She is an instructor in the Marriage and Family Therapy Master's Program. She works across multidisciplinary healthcare teams, including medical residency and nurse education. She's got a focus on biopsychosocial and relational health. Dr. Goodman, would you like to take the floor?
Yes, thank you, Dr. Trudeau. Appreciate it. And yeah, I thought you said you weren't going to use the whole spiel, so
I didn't use all of it.
oh, fair enough. Well, welcome everybody, and I'm gonna just jump right in here. I'm glad you all could make it. So as you all are painfully aware, about 14 months ago, family and relationally focused biopsychosocial health services in the US obviously transitioned to telehealth as the primary mode of service delivery across our continuum of care. But now, as many health systems are navigating a return to in-person care delivery, it's clear that telehealth is going to remain an integral part of the healthcare system going forward. But the problem to date has been that there is little clarity for us on specific approaches or measures of quality in family and relationally focused biopsychosocial telehealth care. So today we're going to really look at consolidating and summarizing many of the telehealth competencies and guidelines available from the peer-reviewed literature, as well as the professional organizations that many of us might belong to, and that are relevant to the family and relationally centered telehealth approach that we would like to take. I also want to impart some guidance and examples on how you might go about developing or refining your clinician or care delivery evaluation guidelines or documents in terms of thinking about what is quality, competent biopsychosocial, relational, and family-centered telehealth delivery. And I'm basing that on my own experience and how I've navigated that myself. I'd also like to highlight for you some known approaches to delivering biopsychosocial care that aligns with relational and family-centered telehealth, in thinking about how that also connects to those competencies and what we found in the literature. And then finally, we're going to discuss a case example and apply personal experience as well as our learning about the telehealth competencies to determine next steps. I also had wanted to provide some findings from a quality improvement study that I've been involved in, but we're not going to have time today, so I apologize for that. However, I hope to be able to talk to you about that topic again soon. So there are many different telehealth competency domains found in the literature. And so when we talk about domains, those are really the overarching kind of content areas or themes. And if we were to focus on all of them, we would be here for much longer than this hour. And so today we're really going to just focus on the clinical assessment and care delivery domains, which are essential for family and relationally centered telehealth. And, in the professional organization and peer-reviewed literature, clinical assessment and care delivery really comprises assessment, treatment planning, intervention, prescribing, case management. And there are numerous subdomains that we find in the competency literature, including things like incorporating cultural competence and diversity, and specific competencies for working with couples and families. So in order to evaluate and consolidate and summarize these competencies, what I did was I examined the peer-reviewed literature as well as professional organizations, published competencies or guideline documents, and then looked at noting and summarizing where they overlapped and where the family and relationally centered telehealth content was specified, to be able to know where that's specifically called out versus where just overlaps are existing, but we're not necessarily kind of focusing on how that looks for families or relational groups. So I just want to give my disclaimer that I don't claim that I have summarized an exhaustive list of all the assessment and care delivery telehealth competencies, but all of the domains and subdomain themes related to assessment and care delivery and the literature and professional competencies that I have reviewed are documented here. I also wanted to mention that based on the most common overarching domains found in the literature, I've grouped competencies under the categories of assessment, intervention, and cultural competence and diversity. And this is also very much aligned with one of the major telehealth competency peer-reviewed documents by Hartline and colleagues, who have done extensive work on creating interprofessional telehealth competencies, and they use similar overarching domains. So without further ado, let's get into it. So first here, I have created the domain of assessment with subdomains underneath. And so before I kind of talk about, I just want to introduce some of these acronyms to you. So AAMC is Association of American Medical Colleges. ATA-APA is the American Telemedicine Association and American Psychiatric Association, who work together on competencies. APA is the American Psychological Association. And then we also have AMFTRB, which is the American, or the Association of Marriage and Family Therapy Review Board. And we also have a number of peer-reviewed articles, including one by Hilty, Hartline, Springer. And so those references are available at the end of the presentation. But now I'll just kind of walk you through one of the first things you might notice, because we're family-centered folks here, is that very few explicitly call out or address how these competencies would be put in place with relationally and family-centered care. Although in the context of some of these other competencies, we might kind of assume that's in the environment, for example, with AMFTRB, yet very few are actually noting how this might particularly look in terms of competence with families. So under assessment, what we find are subdomains, including rapport building, assessing or reassessing the appropriateness and readiness for using telehealth. So something that really came out across the competencies was that it is not necessarily appropriate just to assess at the beginning of treatment or the beginning of kind of the utilization of telehealth with a patient population if this particular patient or family is appropriate for that technology, but rather to continue reassessing it as treatment goes on. Another thing was, I was pleased to see how many different guidelines and competencies did note that it's important to consider who from relational systems and family systems should be involved in care and present. And so this was actually something that was mentioned across quite a diverse number of competency documents. And so I think is a good sign in terms of overall our interdisciplinary professions thinking about how we can support patients through their healthcare delivery. Another thing that's interesting to note is with administering tools, tests, and assessments, there was kind of this dichotomy, which was to say some documents might mention making adjustments to those particular assessments or tests, while others noted maintaining integrity of the application. So just for yourselves, kind of considering how are you approaching that and what is appropriate in your own setting and patient population. And so it isn't a one size fits all out there in terms of how people are viewing that in relationship to competence with telehealth care delivery. And another thing that kind of comes through is that all competencies and guidelines around telehealth had mentioned addressing and assessing for risk. However, not all had considered necessarily IPV or other issues that we might consider more common to consider with couples and families. And so just in your own settings, thinking about how that's going to look in terms of what might be considered good quality and competent care given the population you're seeing, and is it necessary to do risk assessment to a greater extent or over a number of different types of risk. So there was actually very little, I was really surprised, on intervention. So many of, as you saw, many of the subdomains from the assessment and care delivery fell under assessment, and very few peer-reviewed or professional organization documents actually talked explicitly about competence in relationship to interventions. So we have very little to go on here. However, several of the documents, several of the peer-reviewed articles were explicitly focused on family treatment. And so the interventions that are found in the literature I reviewed actually all do address relational and family-centered care. So it's kind of a plus and a minus there. So some of the things that really stood out here, obviously, evaluating the safe and effective virtual versions of interventions, and if not, kind of underscoring the thought that it might be most appropriate to change interventions or approaches if the intervention you're trying to use or have been using is not effective or safe. So kind of giving yourself that freedom, if you will, to consider that not all interventions are created equal when it comes to telehealth. Another thing that I thought was fascinating and is really great to consider, I know many of us, I've heard many colleagues who have bemoaned this over the last year, is what do we do when we lose so many of the nonverbal and physical cues? And so this particular intervention talked about increasing the use of questions focused on the physical experience, which may feel unnatural to some of us, but really querying on the body language, the physical experience people are having inside their bodies, asking about relational dynamics in relationship to how they are in relation to one another in the physical space, and really kind of bringing more of a verbal aspect to how to assess what we typically would have done more through physical space and visual cues. Another thing kind of related to that was that clinicians have talked about how they've lost the ability to sort of use their physical body in a space in order to be able to not only assess, but then also intervene when family and relational dynamics are part of what's focused on in the care. And so interestingly, Heartline and colleagues had highlighted that you might be able to use the camera in order to encourage or block specific communication flow, whereas you might have used your physical body to kind of do that through the placement of yourself in space. And also thinking about how do you diffuse intense and chaotic situations to enhance safety. Well, interventions related to that in telehealth might involve, again, the manipulation of people in physical spaces. And we'll talk a little bit more about that when we get to some of the interventions that I found in the literature that have been utilized with families and relational groups in telehealth. Okay. So lastly, I want to talk about cultural competence and diversity. I was very excited to see that there are quite a few subdomains represented across the telehealth competency literature and guidelines. And so there was really much more depth here than I personally expected. And so, and as you can see, some of these subdomains are really covered across a wide swath of the literature and interdisciplinary professions. That being said, of course, you'll note that only one article explicitly talked about how awareness of culture and cultural preferences should be considered in relationship to family and community. And so while it's wonderful to see all these subdomains, we're not yet considering how this might sort of impact our intervention at the family or the family-centered level. But some of the ones that stand out, of course, are being considerate of awareness of culture and preferences, awareness of one's own biases. So important in primary care and integrated care is our consideration of language and interpreter needs, as well as accessibility. And accessibility was defined in a multitude of ways in the competence literature, including not only cognitive, sensory, physical limitations, but also economic limitations. And so you can see here how there may be, within accessibility even, some areas where telehealth provides strength, whereas others provide challenges and barriers even. And then thinking about, how the approaches, models, and skills you're using are attuned to clients' cultural or marginalized experiences, which may not be the same as it was when we were in person. So considering how one approach or model or skill set is going to actually have a different sort of impact or different sort of feeling for people depending on their social locations when they're at a distance. Okay, so now that we've kind of gone over and consolidated the literature and professional guidelines around competence in telehealth care delivery and family-centered telehealth care delivery, I want to walk you through just one possible way of considering how to evaluate clinical care delivery from a biopsychosocial, relational, and family-centered lens in telehealth. There are probably many other ways, and I'll be curious when we have time for questions and comments at the end, whether others have developed other types of approaches to this, but this was my experience and could be helpful to you as well. So first, what I did, we needed to basically determine how are we going to evaluate clinicians' competence in telehealth, recognizing that there are different challenges and strengths to the delivery method itself, but also that clinicians are going to have different strengths and challenges as well, and that the skill sets are not necessarily equal. So we need to be able to evaluate this separate than or kind of in addition to in-person skill sets and competence. And so how I went about this for myself and when we were thinking about it for our training program is to first identify what are those competencies or professional standards that you're already using to evaluate clinicians. So for each of us in our profession, we all have some set of competencies that we're likely basing evaluations on. And so that's sort of the foundation we start with. And then on top of that, I looked at telehealth competencies in the literature, and specifically those inclusive of relational and family-centered focused treatment, as well as, and for many of the fields that you all are in, there are now or have been in the recent years, probably a set of telehealth competencies as well. So you might even layer that on top. Now in integrated care, there's an additional consideration and layer to this, which is that we might want to include or consider multiple professional competency documents, because of the interdisciplinary nature of our work. So for example, if you're wanting to create an evaluation for, say, clinicians across medical and behavioral fields, and really just look at how is telehealth, integrated behavioral and integrated care being delivered in telehealth, you're going to want to look at multiple professions and say, okay, where are the overlaps here, so that we can create that one document. And then the last thing I'll say is, for the clinicians at your site, consider how to replicate your current evaluation format, like the structure itself, if that's working for you. Because you want the telehealth competencies ideally to fit in more seamlessly and feel like they flow with whatever your evaluation, your standard evaluation is. It'll feel more manageable for those who are being asked to complete it. It'll feel like it's easier to sort of incorporate and make part of the norm. There's just like a lot of pros to that, I'll say. All right, now I have to find my buttons. Okay. So this is just a visual representation of an example of how I did this on one subdomain for a competency evaluation. So the subdomain here was diagnostic interviewing. So what I did was, again, I reviewed all the teletherapy, telemental, telebehavioral, and telehealth competency literature, all those synonyms, available as of May 2020 in my case, because that's when we were looking to develop the telehealth evaluation. And so for this particular subdomain of diagnostic interviewing, we already were kind of bringing over the competency standards from our original in-person kind of status quo competency evaluation, which included the AAMFT, the American Association of Marriage and Family Therapy, core competencies, domain 1, admission to treatment, subdomain executive, as well as the AAMFT core competencies, domain 2, which was clinical assessment and diagnoses. And this particular diagnostic interviewing covered perceptual and executive subdomains. Then, looking at that literature review, we brought in the Mahue and colleagues 2017 interprofessional framework for telebehavioral health competencies, because it had relevancy across two of their subdomains, assessment and treatment, as well as cultural competence and diversity. And then we also compared the competency-based professional standards, which in my case was the AMFTRB 2016 document, which really just looked at teletherapy guidelines. And so guideline 5 in particular really overlapped here with diagnostic interviewing, and that's around cultural competency. And then finally, what we shouldn't leave out is our own lived experience. So what do you know, and what do your colleagues know about your experience at your site in terms of what you're seeing, experiencing, what's coming up as particular challenges or strengths for the clinicians at your site in relation to the competency you're trying to measure. So for us, we were thinking about, okay, across these integrated care sites where we have MFT trainees, what is our experience in terms of them conducting diagnostic interviewing via telehealth? I apologize for my dog. He's 13, so he gets to do what he wants. So this is just, I'm going to give you a really concrete example. So that was like the visual of how it all came together. And this is the concrete of what does the actual language and evaluation document look like. So on the competency evaluation diagnostic interviewing subdomain, the description that existed for the in-person version of the evaluation, we actually kept for the telehealth version. And so we were looking at application of diagnostic interviewing skills to effectively gather that biopsychosocial information for individuals, couples, and families in order to guide our assessment, our diagnostic reasoning, our case formulation. and also to adapt unique considerations in the changing context of telehealth. So that was the piece we added, was the how do we adapt this? So here is the original. So what this is basically we at our sites, we use a 5-stage semester competency evaluation. So this is kind of based on the Dreyfus and Dreyfus 1985 stage model of the mental activities involved in direct skill acquisition. So here we're just looking at 3 on the scale of 1 to 5, which is just the proficient level. So over on the left, we have the in-person version. And on the right, we have how was it adapted to telehealth? So you'll notice that what we're really acknowledging here, and again, this is the combination of the literature and the competencies from our profession, is how are you identifying? So at the level 3, we would expect our clinician to be able to identify for themselves adjustments that they need to make in approach, tools, and style to conduct a comprehensive BPS interview, a relational diagnostic interview, and assessment. And then we also added that other assessment approaches to telehealth should be considered with specific populations in mind. And so supervision might need to focus at the proficient level still on being able to really hone in on what is an appropriate assessment approach given the population at hand, knowing the challenges and also strengths of telehealth. So that's just a really concrete example of how we combined all of those different sources to consider how do we look at making this seamless with the original competency evaluation while also acknowledging that there are unique challenges and unique kind of aspects of clinical competence to develop in telehealth. All right, so now I'm going to transition to the literature on family and relational focused interventions in telehealth. So I did a review of the literature and really looked at dividing this into what are approaches pre and early telehealth encounter, approaches for assessment and intervention, approaches to do throughout encounters, and then also special considerations for children, working with children and families when we're using telehealth. And so here I'm just highlighting my findings from the literature based on what's come out, particularly a lot of it in the last year. So when we think about the pre and early telehealth encounter in working with families and family-centered care, one of the things in the literature that came about was thinking about collaborating with family members to establish norms with respect to listening, speaking, and turn taking. As many of you know, it can be very difficult to understand, hear, have a dialogue when a number of people are on the screen. There are delays because of the technology and internet and so forth. So really just starting a family-centered encounter out with establishing some norms around how we'll take turns and speak in order for everybody to really be understood. Another thing that came about was considering how to access the family, how the access to the family's environment can inform assessment and intervention. So an example of that might be you're working with a family that has maybe a young child and the mom, maybe the identified patient is the mom, and you really begin to see, because you're in her home environment, how the child acting out is impacting the mom's stress levels. And so how are you going to take in that information, maybe even ask some follow-up questions to further understand and assess that, and then kind of respond in terms of your intervention based on incorporating that new information. Another thing is, and these are kind of 3 different things that came out across the literature, who is going to join the session with the identified patient? Should certain members of the family be present for that encounter? And when and how should they join that encounter? So with the identified patients agreement, some of the literature talked about inviting so-called curious family members, those that you might see walking through behind the camera, those that are kind of off to the side and maybe like commenting, inviting those people into your encounter with the patient's agreement, of course. Another is assessing to find out who's in the room, if anyone, because sometimes patients, as some of you might know, don't necessarily acknowledge that. And then all of a sudden you might get the sense that you're not alone. And then you have to kind of follow up and understand, is it that there's someone else in the room? I'm trying to understand. So kind of calling that out from the beginning and then using that as an opportunity to decide if that person could be invited in to provide more collateral information, support for the patient, etc. And then is there anyone else in the house that could join? And so now that we're in this home environment right now with telehealth, it really reduces the barriers for many people to be able to have a relational or family support with them. We also in the literature found, this question of are the individual patient or subsystems going to need to meet with the clinician separately? So for example, maybe you're going to have parents and children come to the encounter. However, you might need to meet with a parent or parents alone or the child alone. And so thinking about where are with the family kind of solution focused, where are the private and confidential physical spaces available? Could I even utilize having people on separate cameras in separate rooms and then having breakout rooms in order to support that process? And so really thinking about that early with families. Also, an obvious one when working with couples and families in healthcare, but considering how their relational dynamics, other practicalities like whether people are, their work schedules, etc., and then what your encounter or treatment goals are, to think about if individuals in the family should be in the same room within the same camera view, or if maybe they should be in separate rooms and on separate devices. And we think about this especially when we think about high conflict couples and families, situations where we need to assess more for IPV and other forms of risk. So if it feels that you've determined that it's appropriate for the family members to be in the same room, then one of the things in the literature that really came out is being much more directive about how you want the family to set up their chairs or sit, prompting them for how you want to kind of turn towards each other to face or to speak to one another or notice one another, and also directing them as far as how far away you want them to sit from a camera in order to, among other things, facilitate you being able to read body language. What? Okay. I love you too. Oh, and then also thinking about establishing boundaries. So there's a lot of boundary bending this year. We're all in our, we've all been in our living spaces doing our work and so forth. And so boundaries are a little looser than they used to be. And so some people have been joining their encounters for medical appointments and psychotherapy appointments, grocery shopping, driving, making dinner, having a glass of wine. And so really establishing from the beginning, how are we going to minimize the kinds of intrusions and distractions that might get in the way of us being able to accomplish our goal for this encounter today and going forward. And then finally, another thing that I found in the literature was really that telehealth can slow down the progress of treatment. It can slow down, kind of your reaching goals. And so just thinking about spending additional time on rapport building, because some of the ways that we might feel connected to that person are removed, and that slowing process, we really need to set our own expectations as well, that this is going to take a little longer. We need to invest a little more on the front end in terms of our rapport and relationship with patients. So now we'll talk about assessment and intervention. So these are some really, I think, very practical tips from the literature. The first one, and I'm sure a lot of people who have tried this, I personally am very bad at using the whiteboard on Zoom, but you may have more talent than I. So in the literature, it talked about using screen share and also whiteboards to develop different kinds of assessments like a biopsychosocial genogram, timelines, eco maps, or even doing validated assessments. Another thing that was helpful in the literature was incorporating your observations of the relational dynamics, children's behaviors in the home environment, etc., to better attune treatment and support the family with their goals. Oops. All right, and then direct family and relational group in a physical space and the technology setup. We kind of talked about this already, but really this can also be an intervention of sorts. So thinking about how are you arranging the family and in what physical spaces in order to actually have an impact on how they're interacting with one another so that you can consider what treatment goals you want to accomplish. And then utilizing increased verbal direction to deliver the experiential interventions. So very few specific interventions, if any, were really found in the literature. However, one that was more specific was around experiential interventions like enactments and storytelling. And so in regard to those, the literature suggested that it's helpful to increase verbal direction. And really, I think that's a theme overall, is just the increased use of verbal cues and directiveness to be able to facilitate the couple and family in these encounters. And again, I've already kind of talked about this, but with high conflict couples, really establishing ahead of time or early on into an encounter, how are we going to agree that we will handle moments where tensions might rise? So for example, can we all agree to a timeout signal? Can we problem solve with each member of the family in terms of what they want to do if things kind of get a little heated? So can we agree that you'll take a walk and cool down, or step away, or stretch or something? And then sometimes requesting that family members join from separate devices when necessary. All right, and then throughout the encounter, in the literature, things that were talked about were using individual names to prompt participation and direct the conversation. And then also, it helps the clinician themselves to return to foundational listening skills and stay in the session, especially when that Zoom fatigue sets in, which we all experience regularly, I'm sure. Also, again, use of verbal cues to really hone in on some of what is lost with body language and being in the same physical space. How do you feel? What is your body saying? Can you tune into that and describe it to me? Another thing found in literature, good to regularly pause and check in with individuals in the family system about how they're experiencing the encounter, particularly because in the past when we were in person, we might have been able to pick up on those shifts in body language or the shift in the energy in the room, and kind of clue into the fact that maybe someone in the family is not happy about the plan for care or what have you. And so we might need to be more explicit about soliciting that now, since we're not necessarily catching it in the same sort of nonverbal ways we used to. Also, eliciting questions, feedback, and reactions much more often to offset the pitfalls, again, of screen distance, reduced body language, disengagement, and that screen fatigue we're all feeling. And increasing the directiveness in defining and pursuing goals. So we might need to maybe take a little bit more of a directive role and be more upfront, and take maybe a little bit more of the driver's seat in how we're defining and pursuing goals, because there may be difficulty with some of the physical barrier to family members necessarily being able to take that leadership. Also considering flexibility right now, because not all encounters are going to go smoothly. There might be snafus, certain interventions or assessments may fall flat. And so considering how you can be more flexible around that. And then also, this was an interesting one, projecting yourself 15% more. And in the article that talked about this, they kind of likened it to being on television or on the radio, and just that there's a level of our verbal and nonverbal that kind of gets lost through the screen. And so how can we sort of project and animate ourselves a little extra to compensate for that? Oh, yes. And this was another one, just the critical consciousness to mitigate challenges providing cultural, race, and gender appropriate care. So, just as we would in person, but even more so due to the barriers of the disconnection through physical space, being aware and then trying to mitigate any challenges that are related to diversity in order to support inclusion, creating an open and safe space, etc. So lastly, some considerations around encounters with children. So for child and adolescent encounters, thinking about how telehealth can expand the family system available to participate. Again, people can connect from work. They might be more likely to be at home. Maybe they're in the room next door. And so how do you kind of get more of those folks involved, especially with children where the family system and the adults in the home in particular are really going to have an impact on the success of any interventions that you might be trying to implement. Having a flexible plan, again, cannot be understated in telehealth. Encouraging children to actively participate. And so a couple of things with that. One, caregivers might have some anxiety about how children will behave during a telehealth session, and they might have some expectations for that based on what they've experienced this year with virtual school. So really just stress that this is a separate space. Let's suspend those expectations. It's okay if kids move around as long as, confidentiality isn't compromised or, there's not some other concern. And also that there are things that caregivers can proactively do to help you facilitate child involvement. So prepping parents or caregivers that they could have art supplies or fidget toys, stuffed animals, or items to share with the clinician available, all to help them either manage anxiety or stay engaged. On the other end, clinicians also might consider having toys, props, and materials to help engage with and keep the children and adolescents engaged. And then addressing challenges with distractions. First of all, normalizing it, having a playful conversation about it, thinking and problem solving with the family and the child even about different strategies to address that. Can we make a game of seeing how long you can go without being distracted? And also thinking about breaks. So in a 15-minute encounter, we might not so much have this issue, but if you're someone who might be seeing someone for 30 minutes, 40 minutes, 50 minutes, then obviously considering whether a break, even if it's a mindfulness exercise, could be helpful. And then really building on, there are actually some real benefits to technology and the internet. And so adapting and expanding interventions to include video format. So we could mirror or join a child's play. We could use online games, and we can use other virtual tools like the whiteboard on Zoom for games like Grow a Flower, or even to complete a worksheet. And then problem solve with adolescents and their families. Adolescents are difficult to engage. I see this across the literature. That's been one of the main challenges in terms of keeping a patient population engaged and participating in encounters this year. And so thinking with them about how can you help them create a private and confidential space if they're concerned about that, or if they're feeling some self-consciousness or anxiety, maybe actually doing some specific interventions like a desensitization or using screen sharing in order to sort of help soothe some of that anxiety and lower that anxiety so they can participate. All right, so now I have a case example here, and my hope around this is that we can read this case example and then we can consider together in a dialogue thinking about your own experiences with telehealth and what we've learned from the presentation today, what we might what stands out to you from the case, and what kind of competency domains are coming up, and then what kind of assessments or frameworks might we consider using with this family to support them. So the Martinezes are a family of 5. The father is Luis, 36, mother Isabella, 37, and three children, Valentina, 16, Carlos, 14, and Sophia, 12. Carlos, recently diagnosed with a learning disability, has an individualized education plan, IEP. However, his uncontrolled juvenile diabetes has made him miss several days of school per month during the past year during the pandemic. Sophia, who typically received all A's in school, had seen a slight decrease in her grades, and since returning to school in person, reports she's experienced a lot of bullying because of her weight. Valentina, who had gestational diabetes during pregnancy, chose adoption for her baby 2 months ago and is now returning to high school in person. Luis was recently approved for disability following his fourth accident on the job in construction, leading to permanent need for assistance walking and pain medication. Isabella has a history of experiencing depressive and anxious symptoms and medical issues that affect her functioning, including high blood pressure, diabetes, high cholesterol, and obesity, and recently lost her job in food service during the pandemic. At a past primary care visit, Isabella shared with the IBHC that they frequently experience tension in their relationships with one another due to stressors that they're under. The family dropped out of care with their diabetes specialist, and Isabella and Carlos have each had 3 emergency department visits this year. A primary care telehealth visit is scheduled for Carlos today at 5. Isabella scheduled the visit as a follow-up to Carlos' recent ED visit and hospitalization for ketoacidosis. All right, so there's a lot here, although depending on the setting you work in, this actually isn't that uncommon. We often see many multi-stressed and complex family challenges in primary care, and particularly if you're in an FQHC. And so based on your experiences in the presentation today, and I'm looking for your input here, what is standing out to you about this case when we think about biopsychosocial family-centered lens in telehealth?
Jess, this is Lisa.
Hi, Lisa.
Hey. So it's been a long time since I've flexed my clinical muscle. So I'm intimidated and yet excited to try to remember how to do that. But I first begin kind of drawing some parallels and certainly seeing some themes among the family members. And with Carlos being kind of the identified patient at 5, I'm betting that Isabella will be the one that would accompany him, is what my assumption would be, just because I don't know, because I'm a mother and I'm the one that ends up going to the doctor's offices. I mean, I guess if I'm really transparent. And so I guess I would first begin to kind of explore their relationship, since they also share a diagnosis together, and see what the dynamics are between them, and then begin to figure out. I think I like the idea of a genogram to kind of get an assessment for the kind of the relationships among all of the family members, and also to maybe heighten some awareness around some shared, I guess I would think kind of narratively like a shared externalization of something that's making life very tension filled for the family.
Yeah, that's great. Wonderful. You don't know anything at all, huh? Really rusty.
Oh, well, it just still feels like guessing. I might be 45, but it still feels like I'm guessing.
That's great. You gave us some great considerations there. Yeah. Who else? I'll say I made the appointment at 5 o'clock for a reason. I was hoping that people would be home from school. And so even if they didn't plan to attend, we might consider how to involve more of the family, particularly given the shared diagnoses and some of the tensions that have arisen, including around medical diagnoses and concerns. Yeah.
I mean, they're all, I think, like starting at Sophia's age, it's just the beginning of like the really hard ages. And all of them in terms of development are very vulnerable right now to that sense of belonging, and their physical experience is very much impacting that sense of belonging.
Yeah. So I'm curious from others, which telehealth competency subdomains, if you remember, if any of them stood out to you, do you think a clinician would attend to here? And I can kind of actually rewind so that we can look at them. oh, this is going to be real special. Let me just go back. Okay. Yeah. All right. Let's look at assessment. What subdomains might we be attending to in a telehealth session with some constellation of family members from this system?
Hi, Jess, this is Ruth.
Hi, Ruth.
So as I was reviewing the case study, I was kind of flipping into my solution-focused therapy model that really also hones in on considering the relational and overall systems involvement. So particularly, I would probably want to focus on maybe some of the exceptions to some of these barriers to following up with appointments and managing diabetes well. And I would look to see, when mom and kiddo were able to maybe support one another in managing these illnesses. And I would really look for times that they were able to collaborate and function well with managing what has been presented to them.
Yeah, that's great. I love that. Awesome. What other subdomains might you be attending to as a clinician? Whether you're a medical or behavioral health clinician, what are you thinking about for this family as important in the beginning, kind of in this encounter where you're, maybe you haven't met them before, maybe they haven't had a telehealth visit before. So I guess to Lisa's point too, I was thinking about like, how would I like to do, and kind of building off of Ruth actually, I was, from that narrative perspective too, and I think it builds off of this, but creating a genogram, maybe a biopsychosocial genogram using like the Zoom whiteboard rather, and thinking about really trying to explore this family's exceptions and strengths kind of in the face of some really big challenges with their health, and also with some of the social and interpersonal dynamics in the family, just to get a sense of like, where are their resources, how can we sort of build this family up a little to thicken their story about how they're able to manage some of these biopsychosocial challenges. So in thinking about, we talked about some of the assessments and interventions in the literature, and I'll just go back to those now. So are there any assessments or interventions that we discussed today that you think would be particularly helpful for this family in meeting in a telehealth encounter following Carlos's hospitalization?
This is Brett. I think particularly for families who are managing multiple children, just you might see some aspects of the evening routine or some things in the background and being able to validate and build rapport just with the parents' stress and burden and everything they've got to do.
Yeah, really like normalizing and validating. That sounds like a really good idea. I was going to say, this family's had difficulty in engaging with other providers. So kind of thinking about this advice from the literature about, maybe that the rapport building will need to take some extra time, that the process might be a little slower. So you might not get as far as you like today. This family is coming in with some really big health concerns, and yet how are we going to get them to come back? How are we going to get them to stay engaged in care? And so part of that could be just really like normalizing and validating for them their experience and really focusing on that rapport building. Great.
I agree. This is Ruth again. I think that, initially starting an echo map would provide space for each family member to start to provide their perspective on health and wellness and, again, barriers to experiencing health and wellness at this time, or just to address those overall biopsychosocial stressors within the system. And I think that will certainly assist with providing insight for all family members as well as clinician, and really foster strong rapport.
That's awesome. Thank you. Such good ideas. So let me just go. I just wanted to show you the references are listed here at the end. So here's all the literature that was included in both the competency consolidation and comparison, as well as the intervention lists for telehealth. And then we only have a couple of minutes left, but are there any questions, comments, feedback?
Super helpful.
What in particular was helpful?
I think some of the small things that you might not, you might do, but you might not know to evaluate that were very important, like the idea of kind of projecting yourself a little bit more or having the person project themselves a little bit more were interesting to me. And I've definitely jotted down a few authors that I want to grab those articles and read. So really appreciated that.
Great, thank you. Others? Questions? Comments? Concerns?
Just the overall description of domains and subdomains was incredibly helpful. And from my perspective, I did very limited teletherapy for about a 3-month period last late spring to early summer. And I did not have any family compositions. It was all individual. And so a lot of this information was very, very new to me just because I had not had the experience of managing these complexities. So I feel that I have a greater understanding on how to, manage a family system with the telehealth platform. So thank you. Incredibly insightful, Jess.
Thanks. Thank you, Ruth. Thank you for that feedback. Yeah, a lot of this is like pretty basic and essential. On the other hand, we're all building our foundation still right now. So while I kind of wish the literature had more around those interventions, I understand why we don't yet have that, which is to say most of us are still at the very foundational level of developing those competencies to really just be able to facilitate families in a space together for telehealth. So I appreciate that feedback and really echo just, this is where we're at in the literature. And I hope that next time we talk about this, maybe we can talk about, developing further into competencies in the intervention space as well.